Welcome to Inspire Surgeon Anatomy Basic Sciences Part 3. Here we are going to discuss about femoral artery, which is a very important anatomy. With respect to femoral artery, which is a continuation of the external iliac artery and emerges at the level of median gonal point, then it will reach us the adductor canal where it lies underneath adductor magnus muscle, a tendinous opening in the adductor magnus. From there it will reach the popliteal fossa, posterior surface of the lower end of the femur, where it will become the popliteal artery. So we know vein, artery, now that's how it lies. So vein lies medially, artery nerves, then femoral nerve. So in such case, femoral artery gives profunda femoris artery, which is a deep branch of the femoral artery. It also gives a branch of medial circumflex artery. Medially lies femoral vein, and this is very important. Branches in the femoral triangle: superficial external pudendal, superficial epigastric, superficial circumflex iliac artery. Deep branches are profunda femoris, deep external pudendal, and muscular branches. Clinical significance: as we know, this superficial circumflex iliac artery flap is used for groin flap in case of amputated or severe extremity crush injuries. Profunda femoris is a very important, largest branch of the femoral artery, and the sheath artery supplies all three compartments of thigh. The origin lies in front of the iliacus muscle, arising from the lateral side of femoral artery, 4 cm below the inguinal ligament. The profunda femoris gives off medial and lateral circumflex femoral artery and 4 perforating arteries. It supplies adductor muscles and the head of the femur. Sometimes they may ask you about femoral triangle. Femoral triangle is bounded laterally by the medial border of the sartorius muscle, sartorius, and medially by the medial border of adductor longus, and base is formed by the inguinal ligament. So the roof is formed by skin, superficial fascia, and deep fascia. And deep fascia with the saphenous opening and cribriform fascia. Superficial fascia containing the inguinal lymph nodes, femoral branch of genitofemoral nerve, and branches of ilioinguinal nerve, and superficial branches of femoral artery with accompanying veins. So just remember this: we are having superficial circumflex iliac vessels, femoral branch of genitofemoral nerve, 3 nerves, 3 vessels, femoral branch of genitofemoral nerve, ilioinguinal nerve, and vessels, which is superficial epigastric vessel, superficial circumflex iliac vessel, superficial external pudendal vessel, and superficial inguinal lymph nodes. Great saphenous vein, which is a long saphenous vein, which pierces the cribriform fascia and drains into the common femoral vein. It is a very important anatomical landmark. The nerves that lies in the femoral triangle: femoral nerve, femoral branch of genitofemoral nerve to pectineus and lateral cutaneous nerve of thigh. It's very important question. We must remember. They may ask you the anatomy of tongue, they may ask you the lingual artery, they may ask you the submandibular, sublingual, salivary gland. And first important is the branches of the external carotid artery. External carotid artery gives off 8 branches. So the first branch, as we all know, superior thyroid artery, lingual artery, facial artery, occipital artery, posterior auricular artery, superficial temporal artery, and maxillary artery, and postpharyngeal artery. So a very important anatomical landmark, as the lingual artery ascends up and it will go through the hyoglossus muscle and mylohyoid muscle, a geniohyoid muscle, which is arising from the genial tubercle, and attaches to the hyoid bone, and genioglossus muscle arising from genial tubercle, then attached to the undersurface of the tongue muscles. This is your stylohyoid ligament. So this is your hypoglossal nerve, where it will wind around the lingual artery. Lingual artery is tortuous in course, and it will be underneath the surface of the tongue. A very important question with respect to the ansa cervicalis. Ansa cervicalis, predominantly we must know, this is your carotid sheath, where your internal carotid artery lies medially, internal jugular vein lies laterally, vagus nerve, sympathetic chain, and ansa cervicalis. Hypoglossal nerve, which gives a communication branch to the ventral ramus of the C1, and thereby form a descendens hypoglossae, which is a and ventral ramus of C2 and C3 form inferior root of ansa cervicalis. From there we will be having superior biliary fomohyoid, sternothyroid, and inferior biliary fomohyoid branches. Hypoglossal nerve supplies muscles of tongue. All muscles of tongue are supplied by hypoglossal nerve except palatoglossus, which is supplied by the cranial branch of accessory nerve. And ventral ramus of C1 mainly supplies geniohyoid and thyroid group of muscles. So if they ask you about parotid gland, the very important point we need to remember, parotid gland, the arrangement of the structures, which is nerve, vein, artery, everywhere the structures arising in this format, vein, artery, nerve, from medial to lateral. But the substance of parotid, it is called as part is fascio-venous plane, where facial nerve beneath retromandibular vein, external carotid artery. Retromandibular vein is mainly formed by the superficial temporal vein and maxillary vein, and retromandibular vein divides into anterior division and posterior division. Anterior division, posterior division. So this retromandibular vein divides into anterior division and posterior division. Since the name retromandibular vein, which lies behind the ramus of the mandible, anterior division joins with facial vein to form a common facial vein which drains into the internal jugular vein. Posterior division of retromandibular vein joins with posterior auricular vein to form external jugular vein. So this is a very important anatomical landmark. It may be asked in your viva also. And another important point I want you to remember, structures that are underneath parotid gland will be having styloid process, and beneath that we will be having stylomastoid foramen, where the facial nerve arises, internal carotid artery is there, and internal jugular vein is present. So this is a cut section with respect to the facial nerve. So if they are asking you about facial nerve, just remember 3 points. Once, if it is out of the stylomastoid foramen, it is a motor branch. So what are all the motor branches? Posterior auricular branch, posterior billy of digastric, stylohyoid muscle. It divides into zygomatico, cervicofacial, and zygomaticofacial branches. Zygomatico-temporal divides into temporal branch and zygomatic branch. Cervicofacial divides into buccal, cervical, marginal mandibular, and cervical branch. Facial nerve will be having 3 important nucleus. Remember this mnemonic called as SWAT NTS. So, which is special visceral afferent, taste sensation, nucleus of tractus solitaris, and general visceral afferent fibers. So this nucleus, from here it will reach the tongue muscles. Lacrimatory and superior salivatory nucleus. Remember, parotid is by inferior salivatory nucleus, which is our ninth nerve. Submandibular and sublingual salivary gland, which is your superior salivatory nucleus, eighth nerve. So from here, general visceral efferent fibers. These fibers, lacrimatory fibers, will enter the geniculate ganglion, where they will give greater petrosal nerve. They joins with a deep petrosal nerve to form a nerve of pterygoid canal or obedience nerve. From there it will reach lacrimal gland, while zygomatic nerve communicates with the lacrimal nerve, then supplies lacrimal gland. They also, from spinopalatal ganglion, they gives branches to nasal and palatal glands. The motor nucleus, special visceral efferent fibers which are arising from the second pharyngeal arch, they will supply the motor branches. The nucleus of tractus solitaris will reach the tongue muscles via the chorda tympani nerve, which is V3, marginal, which is a mandibular division of trigeminal nerve. They will and superior salivatory nucleus fibers, which enters the submandibular salivary gland and sublingual salivary gland via the chorda tympani nerve. They relay in submandibular ganglion. They will supply the submandibular and sublingual salivary gland. In the internal auditory meatus, they give nerve to stapedius. So here we want to remember 3 points. Once, if it is autostylomustard foramen, it is motor branch, and motor nucleus is special visceral efferent fibers, which are derivatives of pharyngeal arches, and they are posterior digastric stylohyoid muscle and posterior auricular muscle, which is arising from the posterior part, from the anterior, from the substance of the parotid, the zygomatico-temporal and cervicofacial, where it is divided into temporal and zygomatic branch, buccal and cervical and marginal mandibular branch. Nerve to stapedius given in the auditory internal auditory meatus. SPAD NTS fibers will reach the tongue via the chorda tympani fibers. And superior salivatory nucleus and lacrimatory nucleus, which are general visceral efferent fibers. Lacrimatory nucleus, which enters via the geniculate ganglion, which gives rise to greater petrosal nerve, joins with deep petrosal nerve to form the nerve of pterygoid canal. It will relay in spinopalatal ganglion. From there it will give branches to the lacrimal nerve, then it will supply the lacrimal gland. Whereas here spinopalatal ganglion, and from there nasal and palatal glands will also supply. Superior salivatory nucleus supplying sublingual and submandibular salivary gland, which gives rise to the fibers which enters via internal auditory meatus. Then it will reach us via chorda tympani, relay in submandibular ganglion. From there it gives branches. A very important anatomical landmark. This is a very important one because of superior salivatory nucleus of seventh nerve. Seventh nerve gives rise to the chorda tympani branch. Via the lingual nerve, it will reach a submandibular ganglion, which relays to supply submandibular gland directly and sublingual salivary gland via the lingual nerve. The lacrimatory nucleus of seventh nerve, which relays to gives greater petrosal nerve plus joins with the deep petrosal nerve, which is a sympathetic branch which comes via the carotid artery, which gives rise to nerve of pterygoid canal, which relay in the pterygopalatine or spinopalatal ganglion. which relates to supply the glands of nose, palate, pharynx, and pass along maxillary nerve, zygomatic nerve. From there, zygomatico-temporal nerve, lacrimal nerve to supply the lacrimal gland. Inferior salivatory nucleus of the glossopharyngeal nerve, which gives rise to the tympanic branch with full form tympanic plexus, which gives rise to the lesser petrosal nerve, which relays an aortic ganglion, and from there the postganglionic fibers join the auriculotemporal nerve, which is a V3 division, which supplies parotid gland. So this is a very important one, inferior salivatory nucleus, which gives rise to tympanic branch, which relays in tympanic plexus. From there, lesser petrosal nerve. From there, it will reach as aortic ganglion. Postganglionic fibers joins with auriculotemporal nerve, and it will reach as parotid gland. A very important one. So one question they asked you about the inlet of thorax. So a very important point I want you to remember here is structures passing through the inlet of thorax. Here the anatomical landmark: vertebra, trachea, esophagus. So remember 3 points. If you know the carotid sheath, you can able to understand this very clearly. So you will be having subclavian vein and intranjugular vein, which joins to form the brachiocephalic vein on the right side and on the left side. Carotid sheath, in between the internal carotid and internal jugular vein, we have vagus nerve. So right vagus nerve and left vagus nerve. Vagus nerve gives phrenic nerve branch, and internal thoracic artery, which be under the surface of the rib on the medial aspect. Left internal thoracic, right internal thoracic. Similar to the brachiocephalic trunk, brachiocephalic vein, on the right side brachiocephalic artery is present. On the left side, direct branch, which is left common carotid and left brachiocephalic vein. So this is anterior. If posterior, neurovascular bundle, posterior intercostal vein, artery, first thoracic nerve, which is first thoracic nerve, then sympathetic trunk. So very easy to remember. From the heart, you will be having brachiocephalic trunk, which divides into the right subclavian, right IJV, left common carotid, left subclavian artery. So this is how we see here. Similar to the vein, IJV subclavian vein joins to form brachiocephalic vein on the left, IJV subclavian joins to form the brachiocephalic vein on the right. Then anteriorly, under the medial surface, under posterior surface of the medial aspect of the ribs, where we will be having internal thoracic artery, and anterior surface of the medial aspect of the rib, we will be having posterior intercostal vessels and nerves. Structures passing through the diaphragm. We know the mnemonic voice of America: 8, 10, 12, which is your IVC, esophagus, aorta. So now we will be having the central tendon of the diaphragm, where the inferior vena cava along with the right phrenic nerve will enter at the level of T8, esophagus at the level of T10. This is the right crura and the left crura of the diaphragm. Along with esophagus, we will be having left gastric artery branches and right vagus nerve and left vagus nerve. On the level of T12, be having vessels: Assegas vein, aorta, thoracic duct. On either side of the crura of the diaphragm, you will be having sympathetic trunk. A very important anatomical landmark. And from the arcuate ligament, beneath the arcuate ligament, subcostal vessels and nerves arises. A clinical significance: in case of vagotomy, we have to divide the right and the left crest of the diaphragm to reach the esophageal opening. Another one more clinical significance is median arcuate ligament syndrome, where there will be compression over the celiac trunk. Thereby, it may compress celiac trunk and causing ischemic necrosis to the segment supplying it. Now, this is a very important one, as the thoracic inlet very important. On the left side, in between the scalenus anterior and scalenus medial muscle, brachial plexus emerges. Subclavian artery lies in between the scalenus anterior, scalenus medius. Subclavian vein lies in front of scalenus anterior group of muscles. Sometime they may ask you about colonic cancer staging. My favorite question is: T1 tumor invades into submucosa, T2 muscularis propria, T3 pericholic tissues or subserosa, T4 which invades visceral peritoneum, T4A, T4B directly invades other organs or structures. N1 is 1 to 3 node, where N1A is 1, N1B is 2 or 3, N1C is satellite or paracolic nodes, extranodal tumor deposit. N2A is 4 to 6, N2B 7 or more. M0 no metastasis, M1A mets confined to one organ, M1B more than one organ, M1C peritoneal mets. In case of CA rectum, metastasis is M1 lung mets, ovary or bladder, but one organ, whereas M1C is non-regional lymph node metastasis other than M1A. They will ask you this one important question with respect to the mesentery. Mesentery arising from the L1 left transverse process. From there it will reach us to the right iliac fossa. There it will involve the structures DJ flexure, superior mesenteric artery, superior mesenteric vein. It will cross the ureter and it will reach us the IC junction. So the content of mesentery are jejunal and ileal branches of the mesentery, accompanying vein, autonomic nerve plexus, lymphatics, 100 to 200 lymph nodes, connective tissue with the fat. L2 vertebra to the right sacroiliac joint. It crosses the following: a third part of duodenum, abdominal aorta, IVC, right ureter, right psoas muscle. A very important, they will ask you about the clinical significance. Root of mesentery is the landmark for DJ flexure, and inferior mesenteric vein crosses above it. They may ask you about spaces of the hand, palmar spaces, pulse space of finger, mid palmar space, thenar space. Whereas dorsal spaces are dorsal subcutaneous, dorsal subaponeurotic space, and forearm space of corona. This is a digital pulp space where the nutrient artery to the terminal phalanx, which arises, the digital artery gives branches to the terminal phalanx. The one important point, there is a separate branch to the base of distal phalanx and base to the shaft of distal phalanx. So in case of a pulse space infection, this branch will be escaped, whereas all the other branches will go for compromise. So I want you to know about this important anatomy, where you will be having the 5 metacarpals. From there you will be having thenar muscles, hypothenar muscles. In between the metacarpal you are having interosseous group of muscles. From third metacarpal there is a septum which arises. and there is a covering or hypothenar and thenar group of muscles. So the tendons, which is tendons of FDP, FDS lies in the mid-palmar space, whereas in thenar space there will be flexor tendons to the index finger and flexor pollicis longus tendon. This superficial palmar arch lies just beneath palmar aponeurosis, and beneath superficial palmar arch lies digital nerves. So a clinical significance called as Canavel sign. So what is Canavel sign? Pain on passive extension over the mid-palmar space, tenderness and swelling and stiffness present. Mid-palmar space triangular under the inner half of the hollow of the palm, distal proximally flexor retinaculum, distal palmar crease. Communicates proximally with forearm space and distally with facial sheets of third and fourth lumbricals. Anteriorly flexor tendons of third, fourth and fifth fingers, second, third and fourth lumbricals and palmar aponeurosis. Fascia covering enterochae and metacarpal. Medially medial palmar septum. Drainage incision in either third or fourth web space. Whereas thenar space is also triangular under the outer half of the hollow of the palm, that is on the radial aspect, distal margin of the flexor retinaculum, proximal transverse palmar crease. Communicates anterior proximal with forearm space, distally with facial sheath of first lumbrical. Boundaries anteriorly short muscles of thumb, flexor tendons of index finger and first lumbrical and palmar aponeurosis. Transverse head of adductor pollicis posteriorly, laterally tendon of FPL with lateral bursa and lateral palmar septum. Drainage incision in the first web posteriorly. So these are the surgical incisions of the hand, where the incision for the ulnar bursa, radial bursa, the palmar aspect, incision for thenar space, incision for the palm space on the medial aspect, not on the lateral aspect. Incision for mid-palmar space, as we discussed earlier, in the third and fourth web space. Incision for thenar space in the first web space. Incision for digital synovial sheath in the creases. So this is a very important question. Transverse section passing just above the wrist, showing structures passing deep to extensor retinaculum. Medial aspect and lateral aspect. So from lateral to medial we will be having 6 compartments, where, so just remember this, in compartment 1 you will be having extensor pollicis brevis, adductor pollicis longus muscle. In compartment 2, extensor carpi radialis muscle, which is having both longus and brevis. 3, extensor pollicis longus. So extensor pollicis brevis in the first compartment, longus in the third compartment, extensor carpi radialis muscles in the second compartment. Abductor pollicis longus present in the first compartment. There are no abductor anywhere else. In fourth compartment, you will be having extensor indicis, extensor digitorum, anterior interosseous artery, posterior interosseous nerve. In lateral aspect, in fifth compartment, extensor digiti minimi, and sixth compartment, extensor carpi ulnaris. So ulnaris sixth compartment, digiti minimi fifth compartment. Indicis, extensor digitorum in fourth compartment. I know it is difficult to remember. If you keep on hearing this video, you will be able to learn it. Watch this video at 1.25x format. It will be very. If they ask you about liver anatomy, equinoid segment of liver, just remember this. Liver is divided into right and left lobe of liver by the Cantill's line. So you will be remember your fist on the dorsal aspect. So it will be like this. So this is your knuckles. So this is your knuckles. Where is your 5, 6, 7, 8, 2, 3, 4A and 4B. So one is the caudate lobe. So similarly here, segment 5, 8, 6 and 7 and 4, 2 and 3. One is posterior, that is your caudate lobe. So left anterior is 4 and 3, left posterior is 2, right anterior is 5 and 8, right posterior is 6 and 7. So a very important point I want you to remember is ligamentum teres. In ligamentum teres, where you will be having the left umbilical vein. So the left portal pedicle, which is the recurrent branch from the left portal pedicle, which enters the segment 4 and joins with the left umbilical vein. Here the portal vein divides into right and left portal pedicle. The left portal pedicle, the left branch of the left portal pedicle, which goes in umbilical fissure and joins with ligamentum teres. Another important point I want you to remember is right hepatic vein and left scissura contains left hepatic vein. Main scissura contains middle hepatic vein. Middle hepatic vein drains 5, 8, 4A and 4B. Right hepatic vein drains 5, 6, 7, 8. Left hepatic vein drains only 2 and 3. This is a very important anatomical landmark. This is useful in case of segmentectomy. If you are performing right and left segmentectomy, on the lateral side we will remove 2 and 3rd lobe. In case of pediatric liver transplant, median segmentectomy means 4th segment is removed. Time they will ask you about the circulation of CSF fluid. So a very important point, from lateral ventricle, from the choroid plexus the CSF is produced, which reaches the 3rd ventricle, and from there we will be having interventricular foramen of Monroe, and via the interventricular foramen of Monroe, and from there 3rd ventricle via the aqueduct of Sylvius reaches 4th ventricle, where you will be having the foramen of Magenta in the midline, foramen of Lashkar lateral. From there it will reaches the CSF reaches spinal cord. So produced by choroid plexus, absorbed by araconite villi granulations. Function, protection, a medium for brain is placed. CSF volume is 150 ml. Pressure is 10 centimeters of water. So contents, water is 99%, solid is 1%, which contains sodium, glucose and potassium. Extensor retinaculum from medial to lateral. Tibialis anterior, extensor hallucis is longus. Anterior tibial vessels, anterior tibial nerve and extensor digitorum longus group of muscles. Laryngeal cartilages, 3 pad and 3 unpad muscles. So unpad cartilages are thyroid, cricoid and epiglottis. Pad are arytenoid, cuneiform and corniculate. Cuneiform is Risberg, corniculate is Santorini.